Hello everyone, today is the start of a series of lectures on the mitral valve. Assessment of the mitral valve is a huge topic. So today we'll focus on a normal mitral valve by walking through a normal echo, and in that way I can show you the windows and the images required to make a full assessment of the mitral valve. I will show you some abnormal images so that you can compare to normal, and will mention some measurements, but today's talk is not really about pathology or values. We'll get to that in the coming weeks. Okay, so general principles when assessing a valve with transthoracic echo. Firstly, you need to image the valve in multiple views. Any abnormality should be demonstrable in more than one view. For example, a vegetation needs to be seen in more than one view. In each view, you can make some or all of the following assessments. So firstly, with 2D imaging, you need to look at the motion of leaflets. So looking for coaptation, prolapse, flail and tenting. Look at the structure of leaflets. Are they thickened, calcified, or are there vegetations? And also look at annular size related to the valve that you're assessing. We also use Doppler, so colour Doppler, and also pulse wave and continuous wave Doppler when making valvular assessments. There are quantitative measurements which will depend on the pathology and the valve that you're assessing. And then also associated features which help you grade severity of lesions. And these include ventricular size and function, atrial size, concomitant valvular disease, and pulmonary pressures may be relevant too. I guess from an ICU perspective, we're mostly interested in severe hemodynamically significant valvular lesions. And to be honest, you may know that they're hemodynamically significant without having to quantify them in detail with echo. But this is an echo lecture, so here we go. All right, so anatomy of the mitral valve. The mitral valve is a bicuspid atrioventricular valve that separates the left atrium from the left ventricle. Its function is to regulate blood flow in two ways, so forwards towards the left ventricle in diastole, so left ventricular filling, but it also functions to prevent backflow towards the left atrium in systole. And the valve and its apparatus helps regulate the size, geometry, and function of the left ventricle. The valve can and its surrounding apparatus can be separated into 5 components. So there's the annulus, the leaflets, the commissures, the chordae tendineae, and the papillary muscles. So firstly, the annulus is the fibrous ring that the leaflets insert into. It's saddle-shaped, and it actually can change its shape throughout the cardiac cycle slightly. Moving on to leaflets, there are 2 mitral valve leaflets, and each of them have 3 scallops. The anterior mitral leaflet is the larger of the leaflets. It's thicker and dome-shaped. And it does have 3 scallops. So the A1 is the lateral scallop, A2 central, and A3 the medial scallop. It's not actually anatomically divided into scallops, but it's divided pathologically for guidance, and so that you can describe where you are if there's a pathology there, and also compare it to the posterior leaflet. The posterior leaflet is the thinner and more flexible leaflet, and it's described as being crescent shaped, and it does have anatomical scallops. So P1 is the lateral scallop, P2 is the central scallop, and P3 is the medial scallop. The valve leaflets are thin and pliable, and we'll see some pictures of that shortly. The body of the leaflet is called the smooth zone, and the coaptation area at the tip is called the rough zone. And clearly that's a pretty crucial area to observe in assessment of mitral valve function. The commissures are 2 specific sites where the leaflets insert into the mitral annulus. And there's an anterolateral commissure and the posterior medial commissure. The chordae tendineae are thin fibrous strings that attach specific portions of the mitral leaflets to the papillary muscle tips. They're Average length is about 20 millimeters and their thickness about 1 to 2 millimeters. And when assessing the chordae, the key features to look for are thickening, fusion, calcification, elongation, and rupture. There are three kind of levels, I guess, of chordae. Primary or marginal chordae attach at the leaflet tips at the coaptation line, and they attach the tips to the papillary muscles. And these are important because their function is to maintain coaptation of the mitral valve leaflets. The secondary or basal chordae attach at the mid-body of the leaflets, and they provide support to the leaflets. They're thicker and longer than the primary chordae. These ones can rupture without definitely damaging coaptation. And as I said, their primary role is support. And then there on the posterior mitral valve leaflet, there are tertiary chordae as well. And these attach at the base of the leaflets and then connect to the ventricular wall. And they also function as structural support. The papillary muscles are large trabeculate muscles that branch from the LV or come out from the LV, connecting the chordae to the mitral leaflets. There are two. The first is the anterolateral papillary muscle. This supports A1 and P1 on the mitral valve leaflets and also part of A2 and P2. And it has a dual supply from the left, from the LAD and the left circumflex. The posterior medial papillary muscle supports A3 and P3 and part of A2 and P2. And it has a single blood supply, so either the RCA or the left circumflex, depending on whether the coronary circulation is right or left dominant. And therefore, this papillary muscle is more prone to injury from a myocardial infarction due to the single blood supply. All right, so let's look at some loops. We always start in the parasternal long axis as usual, and here we examine the valve firstly in 2D. You can see the anterior and posterior mitral valve leaflets labelled there. The leaflets should be thin, so thinner than 5 millimeters is what's kind of reported and documented, but to be honest, I never, and most people rarely measure them. You just need to look at enough echoes and you'll be able to tell a normal thin leaflet as compared to an abnormal leaflet. The leaflet should be freely mobile on the ventricular side of the mitral valve annulus and should not cross the plane of the mitral annulus on the atrial side. So it's a bit tricky in a moving image, but you can see the white line that I've placed on top of the loop there, which approximates the mitral valve annulus. The leaflets shouldn't be, no part of the leaflet should be prolapsing back into the atrium beyond that line. If any part of the leaflet does cross that line back towards the atrium, that is mitral valve prolapse. In this view, also look at the chordae tendonae. You can't really see them in this image, and sometimes that happens in young people, but also it may be just the cut through has missed the chordae in this image, and if you panned through the valve a little bit, you could be able to bring the chordae into view. So look at the chordae for thickening in particular, calcification, and rupture if it's there. In this view, you can also get an impression of LV function and size to add to your assessment. You can make an impression of LA size as well, and also look at the aortic valve in case there's concomitant aortic valve disease, which may be the case in rheumatic heart disease, for example. Always zoom in on the valve when assessing in 2D. And it's also important to pan through the valve. So you can see usually where we'd start is with the beam cutting through A2 and P2 and imaging those two scallops. But you need to pan through the valve so that you can also image A3 and P3 and A1 and P1 to really localize where the pathology is occurring if there is pathology, but also make sure that you haven't missed anything just because of the way that you're cutting through the valve with your ultrasound beam. So angling the transducer superiorly towards the RV outflow view will image A1 and P1, and angling the transducer more inferiorly towards RV inflow will image A3 and P3. And so when I say pan through the valve in each of the views, that's what I mean. This is just a still image to describe prolapse that I mentioned before. So what you can see is that part of the body of the posterior mitral valve leaflet is prolapsing beyond the mitral valve annulus back into the atrium. So this is an example of mitral valve prolapse. And sometimes it's hard to see in moving images, particularly if the patient's tachycardic. So you may need to, save and slow your images right down and even freeze to really interrogate what's happening with the mitral valve leaflets. This is another example of an abnormal valve to compare to the normal one we saw a couple of slides ago. So in this image, you can see the leaflets are thickened. They look much more thick than the leaflets we looked at in the first image. They're also less mobile, which I think is reasonably clear to see. And they're probably not coapting at the tips. It looks like the tip of the anterior leaflet is almost meeting kind of at the side of the posterior leaflet. So that is an example of abnormal appearance of the mitral valve leaflets, abnormal motion in that it's restricted, and also abnormal coaptation. And this is another example of an abnormal mitral valve. It's tricky to see because it's so fast, and I'm sorry I can't slow it down. But these leaflets are hypermobile, so they're too mobile, and you can see some part of probably the posterior leaflet, but again, it's hard to tell, prolapsing significantly back into the left atrium. And in fact, this would indicate a flail. So prolapse is where the body of the leaflet prolapses back into the atrium, but here you could argue that the tip of the leaflet is actually flailing back into the left atrium. So this would be an example of a mitral valve flail. So next we use colour Doppler in the parasternal long axis view to assess the valve. You want the colour box big enough to capture the area you're interested in and the flows you're interested in. So in this case, it would be, of course, the mitral valve, but also the left atrium and some of the left ventricle. Some people look at, in a zoomed out view, put the box over the aortic and the mitral valve as kind of a screening colour box, and then zoom in on each of the valves or concentrate on each of the valves separately. This looks busy with blood flow kind of going everywhere, it looks like. But what you're really looking for is whether there's a jet of blood flow back into the LA from the LV during systole, and whether or not there's an indication of very high velocity flow through the mitral valve. And again, until you get your eye in and you've looked at more echoes, you may need to slow your image, freeze and slow your image down so that you can time it with your ECG and really make sure that there's no regurgitation in particular there. This is normal. It does look a bit busy, but it is normal. In contrast, this is not normal. So this is an example of mitral regurgitation. So you can see the light blue high velocity flow from the LV through the mitral valve into the LA during systole. This is a reasonably sized jet. I think it would be reasonably hard to miss, but again, it's important that you pan through the valve when you have the colour Doppler on so that you don't miss any small jets. Because it's not always this obvious. This is quite obvious. And again, this is the same patient, but just a slightly different image. They've cut through the valve at a slightly different angle and zoomed in a little bit more. And as you can see, the jet isn't as obvious in this image. Some people, some sonographers will use M mode through the mitral valve to demonstrate leaflet motion. This modality of imaging was more important before our 2D echo imaging got so good. It doesn't add as much now, and it's not something that I learnt to do when I was training, and I don't do it routinely, but some people will, and it is kind of helpful when you're learning, I think. What this normal trace demonstrates is the normal biphasic opening of the mitral valve. So you can see the anterior leaflet has the two peaks, kind of two triangle peaks, and underneath that is the posterior valve, which is slightly discordant in its timing. So this is an image of a normal one, as I said. It's good to have that in your head. So if you see M mode through a mitral valve that doesn't look like this, that could be an indication that the leaflet motion is abnormal, and I'll show you some of those, if not in this talk, in subsequent talks. So after the parasternal long axis view, we move to the parasternal short axis view. And because we're talking about the mitral valve, that's where we'll start. This is a still image just to show you the anatomy, really, because sometimes it's a bit more difficult to see when the image is moving. So what we see is the anterior and posterior mitral valve leaflets when you're in the parasternal short axis view at the level of the mitral valve, and other structures are labelled there. So the posterior medial and anterolateral commissures, and also the scallops of the mitral valve leaflets. And this is what it looks like when it's moving. So it can be a little bit more tricky to see, but labelled nonetheless. So you want, pardon me, here again, you want to look at the valve leaflets. Are they calcified? Do the tips look thickened? You want to look at the opening of the mitral valve. Is it opening at all or not very much at all? And you also want to look to see whether you can actually see the commissures. Sometimes if they're really calcified, you can, and that would be abnormal. And here you also want to look at LV function and septal motion to help you, or to add to your assessment about severity if there's a mitral valve lesion, because severe mitral valve disease will eventually increase your pulmonary pressures and may affect the right heart. This is a normal patient, a normal heart. So if you contrast that previous loop with this one, you can see here that the leaflets are thicker and brighter, indicating that they're more calcified. They're definitely less mobile than the loop before, and not opening as much. And you can actually see the fused commissures in this loop. So you've got the little kind of fish mouth opening, and then the commissures are visible to the side, which is abnormal. In this view, you can also measure mitral valve area using 2D planimetry. And this forms part of assessment, particularly for mitral stenosis, which we'll talk about in a subsequent lecture. But just briefly, the optimal timing of the cardiac cycle to measure planimetry is in mid-diastole, when the valve is open and should be open at its greatest. You need a frozen image, and you also, again, need to pan through to find the narrowest aperture that you want to capture, because there's a difference in measuring the aperture right at the leaflet tips compared to further back where you may overestimate the mitral valve area. So the normal mitral valve area is 4 to 5 centimeters squared, but above 1.5 centimeters squared usually doesn't produce any symptoms at all. So still in the parasternal short axis view, we would then use color Doppler over the mitral valve. Again, this is a normal mitral valve and a normal LV. It can be hard to appreciate that until you've looked at a few, but you need to think about what you're actually looking for. So in this view, the direction of the blood flow is actually perpendicular to the Doppler signal. And so it can be hard to work out what's going on. You need to take notice of where you are in the cardiac cycle. And in diastole, the valve will be open with blood flowing through the valve kind of into the screen. And in systole, the valve should be closed with no flow really back towards us out of the screen. I can't do it here because of the limitations of the presentation medium, but you do need to sometimes slow the image down so that you can really see where you are in the cardiac cycle and work out where blood is flowing. So this does look a bit busy and it can be confusing until you've looked at a few echoes, but this is a normal appearance of colour Doppler over the mitral valve. And this is an example of MR. So what you can see is in ventricular systole, there's a high velocity jet of blood coming back towards us out of the screen, which is the kind of light blue yellow jet. From the mitral valve, you'd pan down towards the apex of the LV to look at the papillary muscles. They're not imaged or not obvious in this picture, but here you would look for them. They are there, and you know, in severe pathology you may see pap muscle rupture and a pap muscle floating around in the LV. And of course you'd pan down all the way to the apex, but we're just focusing on the mitral valve here at the moment, so we'll move on. Next we move to the apical four-chamber view. This is where a lot of our images and measurements are acquired, because you can line the Doppler up quite well with the direction of blood flow through the mitral valve here. But first, again, we need to examine the valve in 2D. So just to really ram the point home, you're looking at the appearance of the leaflets. They should be thin, thinner than 5 millimeters. They should be freely mobile on the ventricular side of the mitral valve annulus, and no part of the leaflet should cross the plane of the mitral annulus onto the atrial side. And again, looking for LV function and size to add to your assessment, and also LA size. And the order of things is not particularly important between operators, but it's important that you have your own order of doing things, so your order of taking pictures and making measurements, because there are a lot of them, and you just need to have a routine so that you don't forget anything, because it's a real pain to have missed a crucial measurement and have to go back. But from this view, we can take the opportunity to measure the LA size. So this can be corroborating evidence or not of a severe mitral valve lesion. So in severe mitral valve lesions, for example, mitral stenosis, you would expect a degree of LA dilatation and enlargement. The normal LA size is up to 34 mils per meter squared. So we measure it by volume. So you want to measure this when the atrium is at its biggest, which is end systole, end of ventricular systole. And you freeze and trace around, and then you also repeat the image in the apical 2 chamber, and from those two measurements the machine will calculate a volume. And then again we colour over the valve, and it's the same in this view. What you're looking for is firstly if there are jets of flow back into the atrium during systole, indicating MR, and whether or not there's high velocity through the valve from the atrium into the ventricle, indicating stenosis of the valve. And there's neither of those things here. This is a normal loop. Here's an example of mitral regurgitation. So again, it's the patient's tachycardic and it's a little bit difficult to see, but you'll see in systole there is a blue jet back into the atrium, or flowing back into the atrium during ventricular systole, which is mitral regurgitation. The next thing we would do here is apply continuous wave Doppler. This is a normal continuous wave spectral Doppler, which indicates a couple of things. So it indicates normal velocity and therefore a minimal gradient through the valve in diastole, and that's represented by the spectral signal above the baseline. And it also indicates that there's no mitral regurgitation in systole, and that mitral regurgitation is represented by a spectral signal below the baseline during systole, and you can't see either of those, or you can't see that in this spectral display. Sometimes your 2D image and perhaps your color isn't particularly sharp or not particularly good quality, but you should still see CW through the valve to see what kind of spectral Doppler display the machine can pick up. In contrast, this continuous wave Doppler spectral shows firstly evidence of MR, mitral regurgitation. So you can see flow away from the probe, so that's below the baseline during systole. And then in diastole, you can also see mitral inflow with increased velocity above the baseline, which has been cut off because of where the baseline is set. But if you contrast that to the image before, which is normal, in this one you can see that there's definitely flow away from the probe below, so represented as below the baseline in systole, which would be consistent with MR, and the impression of increased velocity through the mitral valve during ventricular filling, which is the spectral display that you see above the baseline. Again, important to zoom in on the valve in the apical 4-chamber view, and again subtly pan through the valve, as we've discussed previously, to really make sure that you get a good impression about what's happening at the valve and make sure you don't miss anything. You don't necessarily have to take a picture of, every angle that you pan through, especially if there's nothing abnormal there. If there is an abnormality, obviously definitely image it, but you need to be sure that you have looked at that whole valve and then you have taken a representative image as a recording so that other people can look at it. And when you're zoomed in, again, apply color on the valve. Again, looking to see if there's any regurgitant jets or the impression of high velocity through the valve. And there are some measurements that you take from this view, the zoomed in color Doppler view, which we'll get to later. But it's important that you take this image and have a good look. And again, pan through so you don't miss any subtle jets. So the next measurement that we'll talk about is mitral valve inflows. And this is measured in the apical 4-chamber view using pulsed wave Doppler. Its major use is for the measurement of diastolic function of the left ventricle, but it can also be used in the assessment of mitral valve pathology, not can, it is. The way you take this measurement is by placing the pulse wave Doppler sample volume between the tips of the mitral valve leaflets. And even if you don't have particularly good 2D images, you can usually get a pretty good spectral Doppler of the mitral valve inflows. So what that means is that when you place the sample volume, the little gates at the tip of the mitral valve leaflets, the pulse wave Doppler is going to measure the velocity of blood flow right at that point where the blood's flowing through the tips of the mitral valves. And you get a spectral display like the one on the slide here, and I'll just orientate you to what we're seeing. So we are looking at ventricular filling, so mitral valve inflow, ventricular filling. And ventricular filling occurs in ventricular diastole. So it's important that you have ECG on so that you can work out exactly where you are in the cardiac cycle and measure the correct values and measure the correct waves. So the first taller wave there is the E wave, and this represents early diastolic filling, which is the most of the filling of the ventricle. The smaller A wave represents late diastolic filling, or the atrial contribution to ventricular filling. When you're assessing diastolic function, the ratio of these two velocities, or the ratio of these two waves, is used along with some other measures. The relevance in mitral valve pathology is that, particularly in MR, patients with severe MR have very dominant early filling. So that means an increased E wave velocity due to the increased diastolic flow across the mitral valve. So in patients with severe MR, their E wave velocity is usually more than 1.2 meters per second. And so I just wanted to orientate you to this this image and this spectral display, because we will talk about it later. A low E velocity and a higher A wave, so A wave dominance, virtually excludes severe MR. And this is another spectral display, but it's a bit different. This image shows pulmonary vein flow, and this is pulse wave Doppler of pulmonary venous flow. And again, it's performed in the apical 4-chamber view. And colour flow imaging is useful here because it allows us to locate the pulmonary veins and then put the sample volume in the correct position. So the sample volume, or the gates of the pulse wave Doppler, is placed about 0.5 centimeters into the pulmonary vein for optimal recording of these spectral waveforms. And what you see here labelled is the S wave. So this wave occurs during ventricular systole, and flow occurs from pulmonary vein into the atrium due to atrial relaxation, but also because of mitral annular descent when the LV contracts. The D wave occurs during ventricular diastole, when there's forward flow from the atrium into the ventricle, which of course would encourage flow from the pulmonary vein into the atrium. And then below the baseline, you'll see the AR wave, which is the atrial systolic reversal. So when the atrium contracts, there is some retrograde flow of blood from the atrium into the pulmonary vein. And you can see that happens just after the P wave. So this is a normal trace in young people, so in people less than 40, and this patient example is less than 40. So the D wave predominates in young people less than 40. As we age, the SD ratio increases, so the S wave becomes more predominant. The pulmonary vein flows can be helpful in the assessment of MR. As MR severity increases, the S wave decreases, and in severe MR, this culminates in systolic flow reversal at the pulmonary veins. And you can see here, so this would be more consistent with an older person pulmonary vein flow. So the S wave predominates. And as the MR severity increases, the S wave gets smaller. And that can be also, you might see it referred to as systolic blunting. And then in the severe case, you see systolic flow reversal. So now you see the S wave is in the opposite direction below the baseline. So now we can move on from the apical 4-chamber view to the apical 3-chamber view. And again, the valve is imaged in 2D, just like we have in all the other views. And again, this is a normal apical 2-chamber. You will colour over the valve here again and panning through to make sure that we haven't missed anything subtle. And if you haven't been satisfied with the apical 4-chamber images, or you've been unable to adequately line up your Dopplers, you can repeat or perform measurements that we've discussed previously in this view. So you could CW and pulse wave Doppler through the valve in this view as well. For example. And here we have an apical 3-chamber view. Again, you would look at the valve in 2D, and I've already added a colour box or the colour image here and colour over the valve as well. At least get 2D images and colour Doppler over the valve in the apical 2-chamber and the apical 3-chamber, and repeat any measurements that you deem necessary. Of course, an echo would also include subcostal views right at the end. I haven't included those in this talk. So that completes the presentation on assessment of a normal mitral valve. Thanks for listening.